Encephalomyelopathy E. Parkinson's disease. 16. A 45-year-old woman undergoes investigation for conductive hearing loss. History reveals several previous ear infections. Direct visualization with an otoscope shows a mass behind an intact tympanic membrane. Coronal CT imaging demonstrates a soft tissue mass located between the lateral attic wall and the head of the malleus. There is blunting of the scutum. The mass does not enhance post-contrast. What is the most likely diagnosis? A. Chronic otitis media. B. Cholesterol granuloma. C. C. Cholesteatoma. D. Rhabdomyosarcoma. E. Squamous cell carcinoma. 16. C. Cholesteatoma. A cholesteatoma consists of a sac lined with stratified squamous epithelium and filled with keratin, essentially skin growing in the wrong place. They can be acquired 98% or congenital 2%. Most acquired cholesteatomas arise in the superior portion of the tympanic membrane, pars flaccida, and extend into Prusox 144. Module 6. Central nervous and head and neck answers. Space where they can cause medial displacement of the head of the malleus and erosion of the bony scutum. The characteristic imaging feature of a cholesteatoma is bone erosion associated with a non-enhancing soft tissue mass. Complications can be INTRA temporal and intracranial, INTRA temporal, ossicular destruction, facial nerve paralysis, labyrinthine fistula, complete hearing loss, automastodectomy. Intracranial, meningitis, sinus thrombosis, abscess, CSF rhinorrhea. Refs, Dannert p. 381. Carcinoma. 17. A 52-year-old man with known chronic myeloid leukemia complains of left-sided facial pain. Plain radiographs show a poorly defined lytic lesion centered over the left maxilla. Further imaging with CT and MR demonstrates an enhancing, homogeneous mass with infiltrative margins, which returns intermediate signal on T1 and T2 sequences. The most likely diagnosis is A. Granulocyticsarcoma. B. Lymphoma. C. Osteomyelitis. D. Myeloma. E. Neuroblastoma. 18. A 28-year-old 381, Psalm and Curtin p. 1184. 17. A. Granulocyticsarcoma. Granulocyticsarcoma is a rare complication of acute and chronic myeloid leukemia, AML and CML, occurring in approximately 3% of patients. It is a soft tissue infiltrate of immature myeloid elements. The mean age at presentation is 48 years, and most patients present with a solitary lesion. In the head and neck, they have been reported in the skull, face, orbit, and paranasal sinuses. Extramedullary lesions have been reported in the tonsils, the oral and nasal cavities, and within the lacrimal, thyroid, and salivary glands. They are also referred to as chloromas, a term used to describe their green color seen on sectioning. The prognosis of patients with AML does not change in the presence of a chloroma. However, in patients with CML it may represent worsening of the disease, as their presence is associated with the acute or blastic phase. Phase. Approximately 30% of patients with chloromas have no hematological disease at the time of presentation. Ref. Psalm and Curtin pages 302-303. Year-old woman presents with a mass in her neck. She gives a history of multiple parotid abscesses, which have been refractory to drainage and antibiotics. The mass is located at the anteromedial border of her right sternocleidomastoid muscle. Ultrasound demonstrates a compressible mass with internal debris, which is devoid of internal flow on Doppler imaging. MRI shows a cystic mass consisting of a curved rim. 130. Module 6. Central nervous and head and neck. Of tissue pointing medially between the internal and external carotid arteries. There is slight capsular enhancement. What is the most likely diagnosis? A. Cervical abscess. B. Necrotic neural tumor. C. Submandibular gland cyst. D. Necrotic inflammatory lymphadenopathy. E. Second branchial cleft cyst. 19. A 72-year-old man from a nursing 303. 18. E. Second branchial cleft cyst. Failure of involution of branchial clefts can lead to branchial cleft cysts, fistulae and / or sinuses. Second branchial cleft cysts account for 95% of all branchial cleft anomalies. Male and female incidence is equal, and the typical age of presentation is 10-40 years. Second branchial cleft cysts are classified into 4 types depending on their location. The most common is type 2, which occurs along the anterior surface of the sternocleidomastoid muscle, lateral to the carotid space, and posterior to the submandibular gland adhering to the great vessels. On CT/MR the beak sign is pathognomonic. This is a curved rim of tissue pointing medially between the internal and external carotid arteries. Ref. Dannert pages 376-377. 19. A. Nursing home presence to the accident and emergency department. Nurses have noticed increasing confusion following a fall 6 days earlier. His inflammatory markers are normal. A non-contrast CT scan of the head demonstrates a crescent-shaped collection in the left frontoparietal region. The collection is isodense to CSF, and there is no midline shift, nor hydrocephalus. On T1, weighted MR imaging the lesion is iso-intense to CSF. The most likely diagnosis is A. Subdural hygroma, B. Brain atrophy, C. Subdural empyema, D. Chronic subdural hematoma, E. Enlarged subarachnoid space. Subdural hygroma. This is a traumatic subdural effusion, which shows up as a localized CSF fluid collection within the subdural space. They present in the elderly or in young children usually 6-30 days following trauma. The majority are asymptomatic, but patients may present with increasing confusion or headaches. They are devoid of blood products on imaging, unlike chronic subdural hematomas. Subdural hematomas are also more likely to cause effacement of the ventricular system and loss of the normal sulcogyral pattern. Normal inflammatory markers and lack of pyrexia lessen the probability of an empyema. Ref. Dannert p. 329. C. Subdural empyema, D. Chronic subdural hematoma, E. Enlarged subarachnoid space. 20. A 40-year-old man undergoes investigation for seizures. Head CT with and without contrast shows a large, round, sharply marginate, hypodense mass involving the cortex and subcortical white matter of the left frontal lobe. The mass contains large nodular clumps of calcification. There is surrounding edema and ill-defined enhancement. MRI demonstrates a heterogeneous mass, which is predominantly iso-intense to gray matter on T1 and hyperintense on T2. There is moderate enhancement. What is the most likely diagnosis? A. Astrocytoma, B. Ganglioglioma, C. Ependymoma, D. Glioblastoma, E. Oligodendroglioma. 21. A 50. 145. Module 6 Central nervous and head and neck answers. 20. E. Oligodendroglioma. This is an uncommon glioma which usually presents as a large mass at the time of diagnosis. Mean age is 30-50 years and they are more common in men than women. The majority are located in the frontal lobe, 60%, although they can occur anywhere within the central nervous system, including the cerebellum, brainstem, spinal cord, ventricles and optic nerve. Large nodular clumps of calcifications are present in up to approximately 90% of tumors. Cystic degeneration and hemorrhage are uncommon. Prognosis depends on the grade of the tumor. High-grade tumors show 20% 10-year survival, whereas low-grade tumors show 46% 10-year survival. Although astrocytomas can calcify, the calcifications are rarely large and nodular. Glioblastomas rarely calcify. Gangliogliomas are more common in the temporal lobes and deep cerebral tissues, and the majority of them, 80%, occur below the age of 30 years. Ependymomas often demonstrate fluid levels due to internal hemorrhage.